Additionally, if your patient has their skin condition, remember they have dementia, so you won't be able to notice whether they have a runny nose, whether they have a fever, whether or not they have a rash. They might forget to eat. They might not even know that they're wet because, again, we said they're confused. They can't make sense of their world. All right, so you're going to have to notice these things. So we talked about delirium, and you understand it's a state of acute confusion, and we looked at the causes of delirium. When your patient is delirious, what do they behave like? They're agitated, they're restless, they're fighting, they're spitting, they're calling your names, they're behaving irrationally, right? They're not sure what's happening. They're irritable, they're disorienting, they have trouble focusing, they have changes in sensation and perception. They have decreased short-term memory. So they might be 25 years old and delirious. A 25-year-old is supposed to remember what happened this morning, right? But here they have short-term memory and they may eventually develop loss of consciousness. All right? There is a little yellow box for you talking about communicating with patients who are confused. And it says, when communicating with patient who's confused, keep your voice low. Do not raise your voice or shout. Use their name and speak clearly in simple sentences. Do you know why you're using their name? So they will, right, it reaffirms who they are, right? Quite often we have them so confused, they don't know who they are, they don't know who you are, they don't know where they are. And so just telling them where they are, who they are, the time of the day, introducing yourself each time you see them. This is a perfect case for wearing uniforms, right? We had cases where we brought in a caregiver to watch a patient and he was jumping on her. He was jumping because she showed up in jeans and t-shirt. Like she was a home care provider and she showed up in jeans and t-shirt. And we had to move her from the room to the lobby where everybody was so we could see her. And he still kept jumping on her. And she called and I said, she said, how can I help you? She said to me, he will not stop jumping on me. And I said to her, where's your uniform? And she said, it's in the car. I said, okay, I'll stay until you put it on. And she go put her on a uniform. I said, tell him who you are and what you're here for. And his whole behavior changed. You see that? Trying to take off her clothes. Inappropriate sexual. You see that? He thought she was there as his friend. He didn't understand the fact that she was his caregiver. All right. So we look at that. Use facial expression and body language, and we're going to learn more about that as we go on. Reduce distractions. Be gentle and try to decrease fears. And distractions, when you talk about your patient, who's cognitively impaired, things like people making noise in the background, or the TV is high, or music, or there's a lot of clutter. When you go to the clinical area, really cool things is you're going to go in the morning time. So when you go to the clinical area, you realize it's like prime central station. Remember all the members of the care team that we talked about? They are there. And the family's there, the clients are there, and the doctors are there. And so it becomes a very busy place. It can become a very distracting place. And we're supposed to keep our voice down, but not everybody does that. We lose sight of the fact that we're supposed to be quiet because this is a care environment. And so it's overstimulating. The alarms are going off, the TV is going off, that sort of thing, so that it's pretty distracting for your patient and can be disturbing. All right, so we're going to look at dementia because this is most of the chapter. The rest of the chapter is about taking care of patients with dementia. Right now we said dementia is what? Chronic what? Confusion. Right? So we said dementia is chronic confusion. And we said chronic, and the words they use to define dementia are progressive degenerative. And if a disease is progressive, it means that it gets worse over time. And it's degenerative, which means what? When something degenerates, it does what? Very good, it dies. Progressive means it gets worse over time, and degenerative means that the cells are dying. So your brain cells are dying in dementia. All right, so we have dementia being chronic confusion, and general term that refers to serious loss of mental abilities, thinking, remembering, reasoning, and communicating. As dementia advances, the patient loses greater abilities, right? So it's reverse, almost like reverse chronological aging. Remember when we looked at development, we said they start from a state of being totally dependent to becoming more independent, right? When we talked about lifespan, the entire lifespan when they grow up. But as they develop dementia, they go in reverse decline. Which is pretty, devastating. One of the facilities I worked in, they had us do, every year we had to go on a computer and do workshops, in services on dementia. So you have to match the age group with the behavior, which is pretty interesting, in reverse order, that is.
My great grandfather, he had dementia, and my grandma and I would have to stay over there sometimes because my grandma started to have to go out to like babysit or whatever. And it was just heartbreaking because I remember like the person he used to be, he was so just like independent and everything. And back in India, he was like the man of like 5 pounds, and like here he's just so like dependent. He was only asked my grandmother, "Oh, who are you?" And my daughter, "Oh," and later, "Who are you?" And my daughter, "How much older am I than you?" And stuff like that. And it's just like heartbreaking to see that. So that's why like when I was looking at that, like it reminded me of him. And then when he passed away, it was at home, and like the whole family, like like a family of like 100 people. So we're all there, and like we saw him pass away. So it was just like it's very sad thing.
It is. And when you take care of these patients, you're going to find that the family members come in and they're heartbroken. And you have to comfort them. And so the same guy is just going through, it's not him, it's the illness. And you see them exhibiting really strange behaviors, and it is heartbreaking. I do like patients with dementia, even though they're difficult to work with, because you get to be creative in caring for them, right? As long as you can acknowledge that they are people and it's not their fault. The behaviors are different, and so you can get to be creative in working with them. All right. So we talked about that. We did, Madame. We started chapter 5. We defined cognition as the ability to think and reason, and we said the opposite of cognition was confusion, and therefore we defined confusion as cognitive impairment. So a patient who's cognitively impaired is confused, or a patient who's confused is cognitively impairment. We went on to define impairment as the partial or complete loss of a function. All right, and so we looked at guidelines for care for patients who were confused. We didn't care if the confusion was acute or chronic. We differentiated between acute confusion, which we call delirium, and chronic confusion, which we call dementia. We said dementia was progressive, it was degenerative. We looked at the causes of delirium, and we said most of them are reversible. The way you fix that is when you fix the cause, your patient should go back to normal. We said hypoxia, hypoglycemia, hypothermia. We said an injury. We said infections. We said a number of drug alcohol intoxication. We said a number of factors can contribute to delirium. And the way we fix it is fixing the cause. Whatever the cause of delirium or dementia, what we were interested in, which we were really interested in, is guidelines to care for the patient who is confused, because we are going to be at the bedside. It is your responsibility. And the first order of the day is safety. You have to make sure your patients are safe. And so our first guideline was do not leave confused residents alone. And so the question is, you have 8 or 10 patients. How do you not leave your confused patients alone? How do you think you accomplish that? Take them to activity. So you realize you're working as a member of a team of people, right? And I think Nevia said, I got you there. No, and Nook just said, oh my goodness. And Nook just said we should take them to the day room. If you go to most facilities, they have a day room, and each CNA is assigned to the day room. So you're gonna go to work on time, know those patients that are at risk for falling, those patients that are at risk for wandering, those patients who are confused, get them up, get them early, and get them to the day area. Additionally, the nurses are supposed to develop methods to prevent falls or wandering, and so we have alarms. So we have bed and body alarms that we can place on them, right? And we take them out so they can be monitored. Once your patient is confused and it has been determined to be at risk for wandering or falling, you now have to do documentation. So there are patients who have constant monitoring or every 15-minute monitoring. There are those who we have to document on every hour, and those you have to do every couple of hours, every 2 hours, that sort of thing. And this has to match up with the state guidelines, because when the state comes in, they're looking for the documentation. Remember, if it wasn't documented, it was not done. All right, additionally, we said some more guidelines caring for patients who are confused. We said, well, what? Do not leave them alone. Check your body language before you go to take care of them. Make sure the environment is safe. Speak clearly, speak slowly, speak in a lower tone of voice. Remind them of who you are. Tell them everything you're going to do when you do it. Talk to them about plans for the day. And later on, we're going to see us developing routines. And we talk about crossing off things that we weren't doing. Once they've been completed, right? So you're patient, and that we said that was reality orientation. All right, and now we started looking at dementia. We said dementia was progressive, degenerative, loss of cognitive abilities. It doesn't come back. It's degenerative, the cells are dying, so it's not going to come back. Do you see that? So the causes of dementia. Let's look at the causes of dementia. We said the causes of dementia were what? The number one cause is Alzheimer's disease. Then we have multi-infarct or vascular dementia. Remember when we talked about diabetic patients, we said they develop vascular problems? This is one of their problems. They have lots of mini strokes. And over time, they develop dementia, because once you have a stroke, the blood supply to that area is gone. So the cells are going to die. You agree? Okay. Then we have Lewy body dementia, we have Huntington's dementia, we have Parkinson's disease. And I think we looked at Parkinson's one earlier in the literature. We did? Okay, very good. So we're going to look more closely at Alzheimer's disease, since it seems to be the most troublesome of them all, right? Alzheimer's disease is the most common cause of dementia in the elderly. The Alzheimer's Association estimates that about 5.2 million Americans are living with Alzheimer's. And guess who's affected more? Women are more. Hello, congratulations. You finally outdid your husband, right? Probably because women live longer, you think? All right. I don't know. I don't know. All right. Alzheimer's disease or confusion or dementia is not a normal part of aging. So even though it's so common, they list it as 1 in 8. Do you see that? 1 in 8 elder Americans will develop or are likely to develop Alzheimer's disease. Okay, so let's look at Alzheimer's disease. In Alzheimer's disease, what happens is the nerve cells. You know how in the brain, the nerve cells talk to each other by Wi-Fi. So in Alzheimer's disease, they tangle up and they die. Right? So in Alzheimer's, and then they form protein deposits. So when they get together, they get hardened like cement, and then they die. What's happening to the communication? Because remember, the brain is a communication center. They need to send and receive messages so we can stay functional. Right? So in Alzheimer's disease, they calcify. Now you understand why the behaviors are the way they are. So there's no communication, there's no interpretation. Remember, we need to receive messages, you need to interpret it, you need to process it, and you need to decide on the feedback. That's what the brain does. That's the whole communication circuit. But in Alzheimer's, there's calcification, so there's no communication happening. So the behaviors are erratic and they're haphazard, right? So we talked about that. The diagnosis of dementia is difficult. So first, remember that movie? He starts forgetting that he placed his orders. And when people forget stuff, generally in dementia or alcoholism or drug abuse, they make stuff up to fill the gaps. So that's called confabulation, right? See how he would insist that he placed the orders because he forgot. He was trying to cover until it gets to the point where they can't cover anymore. And then they start to fall apart. You see that? And usually it's noticeable by the people around them. Pretty unfortunate, right? So it's difficult. We're going to take them to the doctor. They're going to do a couple of tests. They're going to do CAT scan. They're going to do blood work. The length of time it takes from the disease to progress can be 2 or 3 to 20 years. That's a long time. Right. Symptoms of Alzheimer's disease appear gradually, begins with memory loss. The symptoms get worse over time, and that's what we said, they are progressive. People with AD may get disoriented, they may be confused about time and place. Communication problems are common, and you saw that lady with aphasia. They may not be able to recall a word, they may not be able to say a word, they may look at something and not be able to tell what it is. It's pretty disturbing, right? I get disturbed when I can't remember stuff. I take this a moment for medication. Probably I'm just too tired. All right, disease progress. The disease progresses to complete loss of all functioning. All right, and eventually they lose the ability to perform their ADLs, to care for themselves. Right? Again, we see loss of independence. Each person with Alzheimer's disease will show different signs at different times. Some skills will last longer. One of the typical skills we see is music. They said music appeals to different parts of the brain. And so I can give you an example of a lady we used to have in our long-term care facility. And she was as confused as a bat. We couldn't do anything with her. Somebody always had to be there to guide her, to walk her through, reset everything. But on a Sunday evening, she would host the most beautiful piano concert for us. You'd think you were at Carnegie Hall or the NJCAP or something. When she was done, oh my God, it was awesome. But when she got up from the piano, we had to take her back to her room because she just wasn't able to, or take her to dinner or wherever she had to. This is really remarkable that she played such fine pieces and she was unable to perform her ADL. So that's interesting, right? They might remember numbers, they might not remember to read, they may remember to read, they may not remember numbers. So the loss of abilities can be a hazard, all right? And they are going to be unpredictable. Skills that I've used over a lifetime will last longer. Some people can play instrument, we said, and some, even after they've lost most of their abilities. It's important for you to encourage independence. And independence means what? Sorry. Doing things for yourself, right? So you're going to allow your patients to do as much as they can for themselves, regardless of what signs and symptoms your patient may show. So we see, keep them active, working, socializing, and reading, problem solving, and exercising should all be encouraged. All right? Tasks should be challenging but not frustrating. We're going to help our patients to accomplish these tasks. You should encourage them to socialize, read, work, problem solve, and exercise to keep their minds and bodies active. There are some attitudes that are going to be helpful for you if you're taking care of patients with Alzheimer's disease. One, we said it's the disease, not the patient. Don't take it personally. Understand how the patient feels, because even though this is going on, some part of them still know that it's normal, right? It's like watching yourself, right? You can't do anything about it, but it's almost as if you're seeing yourself, and it's like you can't control what's happening. Some of them really don't know, but they're lucid intervals where they know that things are not normal. See that? And so it can be pretty heartbreaking. Work with symptoms and behavior you're seeing, and we're going to talk about this later, how we validate, how we try not to contradict them, how we don't tell them no, different things like that. Work as a team. They might not like you, but they like the other person on your team, and so it is easier for that person to accomplish a task. It's not that they don't like you in a real sense of liking, but they get agitated when you get to work with them, and so they prefer to work with someone. What's interesting is that they have short-term memory loss, so you can go back later, or you can have another team member to carry out a task for you. All right? Work with family members. Family members know them and they know their routine. They know what they like and what they've been doing over the 30 years. Remember the goals of the plan of care. All right, we said our goals are to maintain independence. We can't cure them, can't make them better. You just have to work with them. All right, and then we're going to look at strategies for communicating with patients with Alzheimer's disease. When you to communicate means to exchange information, to get things done, right? So always approach them from the front. Get their attention before you speak to them. Do not try to startle your patient, right? Determine how close the patient wants you to be. Some people prefer what? They don't want anybody in their personal space, right? Some people prefer to have you at an arm's length. They're more comfortable with that. People, based on their culture, based on their individuality, don't like people up into there, especially if they don't know you very well. Once the advised patient get to know you, they will be close to you, they will appreciate you touching them and holding their shoulders and hugging them and using all the nonverbal. But initially, especially when you're new, they're not necessarily going to want you to be in their personal space like that. So you do have to be aware of that. Communicate in a calm area with little background noise. Remember, I told you about the TV and the radio and the other patient going, ay, 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 and everybody talking and it sounding like Grand Central Station. Always identify yourself and use the patient's name. We've seen people terminated because they call the patient honey, grandma, dearie. Okay, honey, grandma. Okay, sweetie, you can eat now. It's not appropriate. It's depersonalizing. It means you haven't taken the time to learn the patient's name. Do you see that? And so everybody frowns on that in facilities. Everybody deprives them of their dignity because you're going to see this. Honey is a term of endearment. Why would they terminate someone for that? But it violates a patient's right to dignity and respect. You can see that, right? Okay. Speak slowly using a lower tone of voice. We said that earlier. Repeat yourself. Use the same words and phrases as often as needed. Use signs, pictures, gestures, or written words to help to communicate with your patient. Break complex tasks into smaller ones. Give simple step-by-step instructions as necessary. In addition, your patient with Alzheimer's disease can be helped with in some specific situation. If your patient appears frightened, try to keep your voice low. Speak slowly in a calm voice. Get rid of background noise and distractions such as the TV. And the TV can be, I think the TV normalizes life for us sometimes, but sometimes it's just too much, all that noise you're not listening to, right? Well, try to see and hear yourself as you're doing. And that means that you have to check your body language. You have to check what you look like, right? Some days you go in and you're not in a good mood and you just don't feel like it. We just want to be in ourselves, right? And you might be pouting or something like that. And you don't really know about it, but the patients are going to interpret it as your displeasure at them. Remember, you have prolonged periods of contact with your patient. Your patient doesn't have contact with prolonged period with too many more people. They're reading you. They're interpreting your actions as relating to them because we said they have cognitive impairment. So it's only natural for them to do that. So you do have to check your body language. Use simple words and short sentences. One of the things I tell caregivers, when you get to the bedside, we tend to talk a lot, especially when you're new, you're nervous. I don't mean to be rude to you, but it's more important to listen than it is to talk. You see that? Because you're confusing your patient with all the talking that you're doing. The patient is trying to catch on to what's going on, but because you're talking so fast and you're talking about so many different things, they're confused. So we want to focus our attention on them, respond to what they ask us, and just provide the minimum clear information that they need. Right. Check your body language. Make sure you're not tense or hurried. What do you do if your patient is forgetful or they show memory loss? What do you do?